Do we have a pointer, or do you use the mouse?
You use the mouse.
That'll be seen. Okay.
Mhm.
Okay.
Good morning and welcome to Medicine Grand Rounds. Today we continue our lecture series on COVID-19, specifically focusing on the associated hematologic complications. We are joined by two of our hematology experts who will guide us through this topic, Drs. Morey and Kristen Sanfilippo. As a reminder, please use the chat function on Zoom to ask questions, and I will mediate a Q&A session after the talk. I saw there's already a question about CME. I'll put that up too. It's in a PDF format, so I'm just going to have to end the slideshow and put that up later, but it will be there. So leading off this morning will be Dr. Blender. He's currently a professor of medicine within the Division of Hematology, as well as the Department of Pathology and Immunology. He received his medical degree from St. Louis University and completed his medical residency at the University of Illinois. He then pursued a fellowship in hematology at the University of Washington in Seattle, before ultimately returning to St. Louis to finish at WashU as a postdoctoral research fellow in the Division of Hematology Oncology. He's been well recognized throughout his career, with highlights including the 1999 Dr. Neville Grant Award for Clinical Excellence, the 2017 Distinguished Faculty Teaching Award, and the 2019 Teaching Faculty of the Year. He holds clinical interest in disorders of iron metabolism, sickle cell disease, immune-mediated hematologic disease, and thromboembolic disorders. Dr. Sanfilippo received her medical degree from the University of Missouri-Columbia and completed a master's in population health sciences at WashU. She then ventured to the University of Pittsburgh Medical Center for her internal medicine residency before returning to WashU for her fellowship in hematology oncology. She has been recognized for her hard work and dedication to research by the American Society of Hematology within the Clinical Research Training Institute. Currently, she's an assistant professor in the Division of Hematology and serves as a staff physician in hematology oncology at the John Cochrane VA Medical Center. She holds interest in multiple myeloma and venous thromboembolism, specifically working to create a unique clinical risk prediction model for venous thromboembolism in multiple myeloma. It's my pleasure to welcome both speakers and turn it over to them as they present COVID-19 coagulopathy.
Thank you, Adam. I hope everybody can hear me okay. I'm in Clopton Auditorium, and there's only the three of us, so pretty small crowd, but hopefully everybody else is up and ready to go this morning. So our topic today is COVID-19 associated coagulopathy with a focus on venous thromboembolism. And I will do the first part talking more about the pathophysiology and some of the laboratory abnormalities, and then Kristen will follow up with a lot more on the treatment and prophylaxis and approach to this disease. So I have no disclosures, and Dr. Sanfilippo's are on the screen now. And as an overview, what we're going to speak about is talk a little bit about some of the background, identification of the clotting disorders that occur in COVID-19. We'll talk a little bit about laboratory testing of hypercoagulable states and how that fits in. Briefly mention stroke in COVID-19. That's a topic that seems to be emerging. And then Kristen will follow up with an extensive talk about the venous thromboembolism that occurs, including the incidence, prophylaxis in the hospital, treatment, and discharge prophylaxis. So I want to begin just with an overview slide looking at the effect of this pandemic. So taken three example countries here, and they're lined up on the x-axis, so the timeline should be about right. The y-axis is obviously not to scale, but you can see the original outbreak was in China. As that faded away, the outbreak in Italy occurred, and then shortly after that, the one in the United States occurred. Now, in the bigger graph in the middle, I'm showing how New York, where the pandemic has hit the hardest in the U.S., compares to Missouri. And so you can see that on March 18th, New York had a shelter in place Before that, they had some limited measures to limit travel, such as Broadway closing, things like that. But then they implemented their full shelter in place on the 18th, but they had already had thousands of cases. On the other hand, here in Missouri, there was a stay-at-home order that for St. Louis County and City that was implemented on March 23rd, at which point we had only a few hundred cases in the state. And my point here is really not so much to make any political statements, but to say that it would be much harder for us to do any research as a single site. So a lot of the early research that occurred here was often from mainland China, some from Italy, and then of the data that early came out in the United States, most of it was from New York. And trying to put this together reminded me of a journalism quote from Philip Graham, who said, "Journalism is the first rough draft of history." And I think we're sort of in that first rough draft today. So one of the first things I want to point out from China was the early recognition of the importance of the D-dimer. So this was a study, relatively small, 41 cases from Wuhan, published in February, showing that if you look at their 41 patients, those that were in the ICU had 3 features that seemed to be significantly more abnormal in the patients that were in the ICU compared to those that were not in the ICU. And one of them that really stood out very early was the D-dimer. The others were the total white count, which was higher in people with that were sicker in the ICU, as well as a more striking lymphopenia. The other graph on this slide shows something similar. Same group of investigators in China looking at 191 cases. It's not a good reproduction, but the red line shows the non-survivors. The blue line shows the survivors, and they looked at the factors that occur that increase the odds of death, of which D-dimer again was an important early predictor of death. So not necessarily related directly to clotting, but D-dimer emerged as a very important early indicator for a poor outcome in this disease. Now, one other paper looking at D-dimer and venous thromboembolism, also from China, they looked at about 1,000 patients from Wuhan, only of which a small number, 25, underwent a CT scan for suspected pulmonary embolism. And this was done on day 10. They don't really tell us exactly how many patients were using DVT prophylaxis, but it was not generally the standard in the pre-COVID era in China. And they noted that patients had a marked increase in D-dimer when they had a pulmonary embolism. And you can see that shown in this table below. So their reference range is less than 1, and we'll talk in a minute on what the units are for this. Of their total 25 patients, those that had a pulmonary embolism had a significantly higher level of D-dimer compared to those that did not, and even more so compared to the overall reference range. So what is the D-dimer? I think it's something just to think about in general, because it comes up throughout all the literature related to COVID. So D-dimer is the degradation product of cross-linked fibrin, and I'm showing on the image here how that occurs. So you start with fibrinogen. There are 2 fibrinopeptides that are released, cleaved off in the presence of thrombin, and that allows the fibrin to polymerize in a linear chain, and also begins some cross-linking through the D portion of the fibrin and the E portion of the opposite fibrin molecule. The next step is the factor 13A, which cross-links this to help give you a solid mesh of fibrin clot. And then this is broken down by plasmin, which ultimately leaves you these little fragments of fibrin, one of which is the D-dimer. So one D comes from one molecule of fibrin, the other D comes from another. Now, there's 2 different assays for this. One is called the FEU, which is a fibrinogen equivalent unit, which bases the reference range on the size of fibrin. The other is called a DDU, which bases this on the size of the D-dimer itself, which is about half the molecular weight of the fibrin itself. And to make it even more complicated, if you look at different commercial labs, there are 9 different units of measure. So you can have milligrams, micrograms, or nanograms per liter, and the same for deciliter in the denominator or milliliters in the denominator. So what do we use? We measure here at Barnes Jewish a fibrinogen equivalent unit, and we report out nanograms per mil. And that's not typically what you see in the literature. And these different D-dimer assays have not been validated among or between each other. So you have to be a little bit careful and think about what you're looking at when you see these D-dimers, because 5 in one lab may be very high, 500 in another lab may be in the reference range. So our reference range is in nanograms per mil, less than 500. And as I'm sure you're aware, D-dimer can be elevated in inflammation, malignancy, variety of clinical conditions. And it's also cleared predominantly in the liver, but a small amount in the kidney as well. And so that may be one of the reasons that the D-dimer goes up in some very sick patients. So one other study, also from China, looking at 183 consecutive patients, looking at a variety of standard laboratory tests that we would do in patients to evaluate for a coagulopathy. And I'll just point out that the PT, which would also be reflected in the INR, D-dimer, and the FDP, or fibrin degradation products, a similar type measurement to the D-dimer, are all significantly higher or abnormal in patients who were not survivors in this study compared to those that were. So again, validating that these coagulation markers are markers for just outcomes in general and clotting specifically. And if you look at this, these would say you would meet the criteria for DIC, even though the fibrinogen is still normal. We often think of fibrinogen as being low in the typical forms of DIC that we see, but in this case, it is normal, and that's held true throughout this literature. So that led to some pathogenetic euphoria as people in the United States early on in the epidemic here, or pandemic here, were trying to think of what the possible mechanism was here. And the term that was used early on was prothrombotic DIC, because the D-dimer was elevated despite the fact that the fibrinogen and platelets were generally not decreased or very little, and that led to a bunch of opportunities for anticoagulation, particularly with unfractionated or low molecular weight heparins, and there's many clinical reports to support this type approach. There's also been some evidence of complement activation, leading to the possibility of a complement inhibitor like eculizumab. Some more esoteric possibilities that were considered were things like hyperviscosity syndrome, because the fibrinogen was elevated, and there actually is a drug that has been used in the past called defibrotide, which breaks down fibrin, had a short life as an anticoagulant, has no life here, it seems, in treating the coagulopathy with COVID-19, and it goes on. And so a lot of these have been looked at, tested anecdotally, and not felt to be significant, and so moved on. So I don't know that any of these has really stood the test of time, but we will talk a little bit about antiphospholipid antibody syndrome in a few slides. So some of the tests that might be helpful, one of them might be a lupus anticoagulant. This is a study from London looking at 216 patients with COVID-19 and severe respiratory symptoms, 20% of whom had a prolonged PTT with no other obvious explanation. And they ran lupus anticoagulant assays on all of these patients and found 91% of them that they were able to test, 31 of 34, to be abnormal for one of two assays for the lupus anticoagulant. Now, these are independent assays, but they're not usually done together. Usually you need a phospholipid dependent step to show that the lupus anticoagulant truly is a phospholipid independent or dependent assay. So this test is a little bit suspect, but nevertheless was published just in the last week or so in the New England Journal of Medicine. And they did not comment about antiphospholipid antibodies. So what about antiphospholipid antibodies? This is a study from a month or so ago from China, looking at 3 ICU patients, all older, who were admitted with typical bilateral pulmonary infiltrates and were intubated. And it turned out that they had strokes, and all 3 of them had anticardiolipin antibodies. And what's unusual about this is they were IgA antibodies. Typically, those are not thought to be very prevalent, especially not independent without an IgG or an IgM. So this was a very unusual finding, but all of these patients had clear evidence of stroke. And so if you were thinking about doing this, testing for this in a patient with COVID-19 and a stroke, you can order IgA anticardiolipin antibodies separately. It can be done. When I was just on service the last couple of weeks, we did have a few cases like this, but we did not find any positive antibodies anecdotally. So none of this, I think, really defines an antiphospholipid antibody syndrome. Really, it requires a combination of testing, and it's just a general slide thinking about the antiphospholipid antibody syndrome. You can have a functional test like the lupus anticoagulant, or one of 2 antibody tests that are done in an immunoassay form. These are either an anticardiolipin antibody or a beta-2 glycoprotein. And some combination of these usually will get you to the diagnosis of an antiphospholipid antibody. The dreaded complication is to be triple positive for all 3 of these, where the risk of thrombosis is much higher, up to a 30 or so fold relative risk increase of clotting in that setting. So, and this may be worsened when you have additional risk factors such as inherited thrombophilias, pregnancy, or maybe in a case like COVID-19, some inflammation. So it is possible that antiphospholipid antibodies may be generated in the setting of an inflammatory response, can also be part of the pathophysiology for a thromboembolism, but that has not yet been well defined. But nevertheless, there does seem to be an increased risk of stroke, and although the incidence of phospholipid antibodies are not defined, I went to the literature, the Washington Post and the New York Times to find some stories about patients who have had bad strokes with COVID-19. They intimate that there's an article in preparation, but I have not seen a large article published from the US on this as of yet. So we don't know how prevalent strokes are, and we certainly don't know how many of those are related to an antiphospholipid antibody. Now, for the next minute or two, what I would like to do is dare to go where most hematologists will not go, and that is to talk about a thromboelastogram, a TEG. The one we use is called a Rotem, a rotational thromboelastogram. This is a picture I took of our instrument in the laboratory last year when I started thinking about this topic. We've had these in our lab since 2012. They're mostly used in the surgical setting to get immediate results related to some aspects of coagulation. So what's done here, there's a blue top tube that is then aliquoted into 4 small cups under these little blue squares that you can see on the instrument. And then a clotting reagent is added to start the clotting to begin. And this is done on whole blood. These instruments are portable, so they can take them to the OR suite, for example, for a liver transplant would be a common use of an instrument like this. Now, there are 5 ways to start blood clotting in whole blood that the Rotem uses. There's what's called an XTEM and an INTEM, which are very reminiscent of a PT and a PTT, if you will. One starts the extrinsic pathway, the other starts the intrinsic pathway. And the difference is that it's on whole blood, so you don't have to spin the blood and take time to make plasma. It's done very quickly. You can also assess directly for the effect of fibrin or fibrinogen. And the way that's done is you start clotting with the tissue factor, but then you block platelet function totally so that you're really just seeing the effect of a clot from the fibrin being formed. There's HepTem, which is basically a way to to do a heparin antibody assay or heparin levels, but this is not used. If you remember, there are 4 wells and we have 5 assay agents here, so the heptem is usually the one that's left out. And then the last one is to look at hyperfibrinolysis and see if that's present as well. So usually 4 of these are run at a time. Here's just a quick principle of the Rotem that we use. So there's this well here that's temperature controlled. There's blood placed directly in it. And then there's this little mechanical device that is rotating back and forth to a fixed point. And so early on, there's no resistance because the blood hasn't clotted. But after, with time, you will start seeing some resistance. And that's what's measured here on this balloon-shaped figure. So I'll show this again, but you can see that it's going back and forth, and that's why it's symmetric on both sides. So as the blood clots from the top to the bottom here, the viscosity increases, the resistance against the probe is increased, and so you see this expanding curve. And then as the system begins to lyse the clot, this will come back together again. And you'll have your result usually within 30 minutes or so. And again, if it's done in the OR, this is what they like to see very quickly. There's certainly many pitfalls with this, but it has found some uses. And obviously in a complicated coagulopathy like the one with COVID-19, this has found a place to try to help analyze this. So here's the components of this curve, and I'm not a thromboelastographer, so I'm not the expert at reading these, but we've tilted this curve on its side. So the x-axis is now time and the y-axis is the amplitude. And you can see the green is called the clotting time. So there hasn't been any fibrin formation yet, so there's not much resistance. And then you start forming the clot and you can measure what's called the CFT or clot formation time. That's how long it takes to get to 20 millimeters of amplitude in each direction. And then there's the clot firmness, which is measured in blue. That's the maximum diameter of this oval. And then you start seeing this lysis looking at the loss of firmness. So those are the key points that are monitored in a thromboelastogram or a Rotem. So here's just an example of 2 assays that are normal. The XTEM, which would be very similar to a PT-INR just done on whole blood. You can see the clotting time, that clot formation, and then the maximum clot formation. Now, if you take out the platelet component of a clot with the FibTem reagent, you're left with just this red shaded area, which reflects the fibrin component. So I wanted to show just one example. So these are the 4 wells. This is from a paper from Italy. Again, not very long ago. They looked at 40 Italian patients on admission to the ICU at day 0, essentially, then day 5 and day 10. And I think you can see that embedded in these blue curves is a dashed line of where it should be, where you'd expect a normal Rotem curve to fit. And all of these are amplified. And again, without looking at these all the time, it may be hard to appreciate, but the people that read these would say this is a very unusual and severe hypercoagulable state. So with all of the reagents that we use to start the Rotem, you can see a increase in the clot formation and the clot stiffness or the firmness of the clot. This is slow to improve over time. So even by 10 days, as the patient was getting better, they still had some evidence of this. 20% of people did have a clinical clot in this study. That wasn't what they were looking for, but they did find those, which would be maybe what you'd expect in an ICU patient. And all of the markers of hypercoagulability were increased, as shown in the Rotem. So I think I'll just summarize by saying I think the COVID-19 associated coagulopathy is really different from DIC and different from most of the other known coagulopathies. Perhaps it would be overlapping with other severe inflammatory states like maybe H1N1 where there was a lot of clotting, but it really doesn't fit the things we usually look for. There's a marked increase in D-dimer. There's an increase in fibrinogen factor 8 and von Willebrand factor. And then there's mild abnormalities in the platelet count, PT and PTT. Those are not usually very striking, but you have a very prothrombotic clinical state. And that is what Dr. Sanfilippo is going to talk about, the approach to looking at the incidence and the prevention and treatment of that hypercoagulable state. So Kristen is here. We're in Clopton, so I'll let her take the stage. Thank you.
Good morning, everyone. I won't go over the summary of the upcoming slides, as Morey kind of did that early on. So we're just going to go over a general overview of venous thromboembolism that we're seeing in patients with COVID-19. So the incidence, as Morey indicated, of VTE in patients with COVID-19 is increased compared to what we typically see in other similarly ill patients without COVID-19. And this incidence varies by disease severity. So of the observational studies that have come out, the incidence on the general wards is anywhere from 1 to 14%. And we'll look at what kind of standard incidence on the general wards in the absence of COVID-19 is. This is markedly elevated. In addition, the incidence in patients in the intensive care unit ranges anywhere from almost 8% to 69%. Some of this fluctuation in different rates that you're seeing here are studies that opted to use surveillance, Doppler ultrasound, or screening Doppler ultrasound. So accordingly, you're going to see higher cumulative incidence. Unfortunately, the two populations of patients where the data is really lacking, where we haven't been seeing observational studies come out, are the post-discharge population, so what happens after they go home, and then those patients who are able to manage their entire disease course as an outpatient. The curves on your right are again showing this significant difference in the incidence of thrombosis in patients with COVID admitted to the ICU versus those on the general ward, which we'll see in the next slide. So this is a summary of the majority of observational studies that have come out looking at incidence of thrombosis in COVID-19. And again, what I've done here is the ones that are underlined actually look at cumulative incidence. The ununderlined ones are really just a snapshot, but I included location on here because I think that's important anytime you're looking at incidence of thrombosis. And so it's known that patients of Asian race have lower risk of venous thromboembolism compared to patients of alternate race. And so seeing that their cumulative incidence or their prevalence is lower, even with screening ultrasounds, is really could be a function of race. And so you have to keep in mind the populations that you're looking at and know that these populations in general are very heterogeneous and may not be able to compare them one-to-one. But as with the prior slide, you generally see incidence of less than 10% in patients on the general ward, and then rates as high as up to 69% as mentioned. So is this different? Is this something new with SARS-CoV-2? Did we not see this with SARS-CoV-1? Overall, there's limited data on thrombosis in SARS-CoV-1. But there was one study that looked at outcomes of patients admitted to the intensive care unit with SARS-CoV-1, published in JAMA in 2003 out of a hospital in Singapore. And what they saw was that the prevalence of thrombosis in their population was 32%. And when they looked at, of the 52% of patients that died, 24 patients died, at least 4 of them in this box on the right had pulmonary embolism as at least a contributor to their death, if it wasn't the sole cause. All of these patients were stated to have received low molecular weight heparin unless contraindicated. Unfortunately, the study did not detail what percentage of patients with thrombosis versus those without received actual anticoagulation prophylaxis versus compression stockings or sequential compression devices alone. And then another question that's been asked, is this really different than other critically ill patients? So we know that patients in the ICU have higher rates of failing prophylactic anticoagulation compared to patients outside of the ICU, which we'll see some numbers. So this was a study that was recently published, and what they did was they took their population of COVID patients, which is the column on the far right, and compared it to patients admitted to their ICU, either with influenza in 2019 in the middle, or just other critically ill patients that were admitted to their ICU 1 year ago. And you can see that pulmonary embolism was significantly higher in the COVID population at 20.6% versus 6.1% in patients admitted to the ICU without COVID. Another question we're asked frequently, well, is this any different than patients with ARDS? So talking about this COVID-19 ARDS-like picture, we know that that population is also critically ill. And so this study looked at that question, and what they did was they took a population of 383 patients admitted to the ICU, 150 of whom had COVID-19, and they generated a comparison population of 233 non-COVID-19 ARDS patients. Now, there was significant baseline differences between the two groups, as you can imagine, in an observational study. And so what they did to try to kind of equalize groups, kind of mock randomize the groups at baseline, was did propensity score matching and to eliminate some of those baseline differences. And you can see that patients with COVID-19 ARDS-like picture had a 6-fold increased risk of pulmonary embolism compared to patients with ARDS without COVID-19. So is this clinically significant? Thrombosis in general is a treatable disease, especially when it's limited to the lower extremities. While there is associated morbidity, thrombosis in the lower extremity should not lead to mortality alone unless it embolizes to the lungs. We have some data on this, one of which comes from a German autopsy series. And so these were some of the first patients in Germany with COVID-19 to die of their disease. And they did kind of rolling autopsies on these patients. And in the first 12 patients, what they noted was 58% had venous thromboemboli at the time of autopsy. So 4 of them had combination DVT-PE, which you can see pulmonary embolism here and lower extremity deep vein thrombosis here. All deep vein thrombosis were bilateral in the patients, so all 7 patients with DVT had bilateral disease. And based on autopsy assessment of cause of death, 25% of patients were listed to have pulmonary embolism as their cause of death. So based on this small observational series, it does appear that VTE and COVID-19 is clinically significant. So if it is clinically significant, what can we do to decrease the incidence or prevent VTE from occurring? Given, before I go on to that, just so given this noted increased incidence and the concern about the clinical significance, this has prompted institutions across the world, as well as organizations across the world, such as American Society of Hematology, American College of Cardiology, international societies, to develop guidance, which is distinct from guidelines, to guide providers in how to treat and mostly prevent thrombosis in COVID-19. And given that the studies that are available are observation, like I've just showed you, and we're lacking trials in this population, a lot of the recommendations, the guidance recommendations, so not mandated, are coming from historical studies in similar risk populations. So if we look at prevention of thrombosis in hospitalized medical patients, this was a meta-analysis of 9 randomized controlled trials, 7 of which were double-blind, with placebo of almost 20,000 patients. And we see that prophylaxis with either low molecular weight heparin or unfractionated heparin significantly reduced the risk of pulmonary embolism and fatal pulmonary embolism, with numbers needed to treat of about 350 to 400 patients to prevent one outcome. There was no significant difference in symptomatic DVT or major bleeding between the 2 groups. And as I kind of alluded to earlier, when looking at the incidence of VTE in general ward patients with COVID-19, where we see anywhere from 1% to 14%. That's markedly higher than even noted in the placebo arm of this meta-analysis. And so looking at that, this is a slide that you've already seen, but what I've added in on the right side were the prophylaxis practice patterns that were noted in the study. And what you'll see here is that as time went on, institutions began to intensify their prophylaxis strategies. So intermediate is classified as not being prophylactic dosing, which would be the equivalent of enoxaparin 40 milligrams daily here, and it's less than therapeutic dosing. So an example with enoxaparin would be 1 milligram per kilogram every 12 hours. Unfortunately, what's not available from these observational studies is, as these practices change with time, how did that influence the incidence of thrombosis over time? And a lot of that is just based on the small numbers that you can see in many of these trials. And so we don't know the influence of these outcomes. Looking at prophylaxis in intensive care unit patients. So this is a meta-analysis of 7 randomized controlled trials of over 7,000 patients. Again, standard prophylaxis defined as unfractionated heparin. An example would be 5,000 units every 8 or 12 hours, or low molecular weight heparin, enoxaparin. Example would be 40 milligrams daily with slightly higher doses guided by obesity. And what you can see in these is in the top comparison against placebo, prophylaxis significantly decreased the rate of DVT as well as PE, with much lower numbers needed to treat to prevent one event. And that's guided by a much higher incidence of thrombosis, so almost 20% in placebo, 7.5% even still with prophylaxis. There was no significant difference in major bleeding. This study also looked at differences between low molecular weight heparin and unfractionated heparin, which is the bottom table. And overall, while they classified PE as significant because the p-value was 0.05, confidence interval does include 1, and aside on DVT and major bleeding, there was no significant difference. Another thing that we know is that standard dose prophylaxis may be inadequate in patients with similar risk of VTE as COVID-19. And so I've listed some of these populations here. So trauma patients have been noted to have elevated risk of thrombosis despite prophylaxis of anywhere from 12 to 65%, burn patients 23 to 60%, and critically ill with sepsis 12.5%. One feature of low molecular weight heparin prophylaxis is there is actually a target peak anti-10A level for prophylactic dosing at 0.2 to 0.5. And this has allowed investigators to assess what are our levels kind of doing in these high-risk populations. And so this was a study of 87 trauma patients who started out on their standard prophylaxis dosing of enoxaparin 30 milligrams sub-Q twice daily. And after 3 to 4 doses, so kind of getting into that steady state, they measured an anti-10A. They did trough level here and found that of the 87 patients, 73 patients had subtherapeutic anti-10A levels. They then dose escalated some of the patients and remeasured anti-10A and documented the dosing which achieved their trough level goal. And you can see the majority of patients were able to achieve that with 40 milligrams twice daily. And 40 milligrams twice daily is commonly cited as an intermediate dose for low molecular weight heparin using enoxaparin. This is very similar findings in 157 burn patients. So again, they looked at peak anti-10A levels. 48% were subtherapeutic on 30 milligrams twice daily. And when they increased levels to achieve target ranges of anti-10A levels, the majority of patients were able to achieve that with 40 milligrams twice daily. And then I just included this last one. So this is patients critically ill with sepsis. And overall, the rate of VTE in this population was that 12.5%. But they did look at what were the risk factors for thrombosis in this high-risk population. What are the risk factors for failing prophylactic anticoagulation. And one of the risk factors that stuck through even in a multivariate analysis was the development of ARDS, where 21% of those patients developed venous thromboembolism in the setting of prophylactic anticoagulation. So we're really at an area of having a gap between what we know is happening and what we know that we should be doing. And that gap really exists because we're lacking clinical trials showing that there are interventions that can improve the outcome. So I just showed you two studies where the standard dose of prophylaxis did not achieve target anti-10A levels. But despite that, there's been really a failure to show if that is clinically meaningful. So if we get those patients into those target anti-10A levels, are we decreasing the risk of venous thromboembolism? And that has been some of the arguments in the guidance statements for COVID-19 and escalation of prophylaxis. This is a study that I'll include that was recently published in JACC that tried to look at, okay, do higher levels of anticoagulation improve outcomes in COVID-19? And so this is kind of really difficult to word, but basically what this was therapeutic dose anticoagulation in a prophylactic or preventative setting. So in patients without a diagnosis of venous thromboembolism. This was a study out of New York of 2,700 patients, and 28% of them were receiving therapeutic dose anticoagulation in an attempt to decrease risk of venous thromboembolism. And again, part of this is due to guidance statements over time, intensifying effort as the incidence of VTE was noted to be high. One important thing and one argument about intensifying anticoagulation is what happens in regards to the bleeding rate or the bleeding risk. Are we putting patients at more harm than benefit? This study found no significant difference between bleeding in patients on anticoagulation, which was defined as major bleeding, versus patients on no anticoagulation. And I'll say this is really a hallmark of some of the observational studies that we're seeing, where the wording in this study, published in a very good journal, is difficult to interpret, where the patients, how many of the patients actually received no anticoagulation, which would be substandard of care in the United States, versus how many were on prophylactic dose. So when they start the study off, they allude to patients being on prophylactic dose, but then as you can see in these kind of survival curves, they list it as no in-hospital anticoagulation, which I would interpret as receiving nothing. So a little bit of critique, just an interpretation makes it somewhat difficult. The survival curves on your left are looking at all patients, so general wards plus ICU, and found no significant difference in survival between higher doses of anticoagulation and no or lower doses. The curves on your right are looking at patients that were mechanically ventilated in the intensive care unit, and there is a significant improvement in survival associated with higher doses of anticoagulation. So we'll move next on to treatment of VTE and COVID-19. What are the recommendations for treatment, and does it differ from patients who have suspected VTE or confirmed DVT or PE without COVID-19? So general considerations for any patient would be renal function, bleeding risk, including lab values, their environment, drug interactions, and then the underlying disease, COVID-19. I will say in terms of bleeding risk that while we can see thrombocytopenia very commonly in the ICU, having its kind of own name when we get consulted on it, that has not been a hallmark of COVID-19. So this box shows a study of 99 patients, and they're presenting symptoms with COVID-19, and only 12% of patients had platelet counts of less than 125,000, and 4 or 5 of those patients actually had coexisting bacterial or fungal infections. So I am not an immunologist and could otherwise not explain this image to you, but I do want to mention hyperinflammation in COVID-19 because it does start to play into recommendations for anticoagulation in patients with COVID-19. So we can see that SARS-CoV-2 stimulates the release of chemokines and cytokines in patients, which stimulate macrophages and neutrophils and lead to the hopeful outcome of viral clearance, but also lead to one of the hallmarks of disease, which is this hyperinflammation, which is believed to be part of the increased mortality in this patient population. And in the same study that I just presented platelet counts to you for, they looked at inflammatory markers and saw that patients presented with elevated interleukin-6, 52%, C-reactive protein, 86%. So laboratory data is kind of showing this hyperinflammation picture at presentation. This was a study that looked at elevated interleukin-6 levels in COVID-19 that was a meta-analysis of studies that have been published. And you can see that patients with complicated COVID-19 or ICU COVID-19 had significantly higher levels compared to patients with uncomplicated or non-ICU admission COVID-19. So again, a feature of the disease. And why am I mentioning this in the middle of kind of anticoagulation treatment? So heparins are noted to have anti-inflammatory properties. This has been known for a long time, with many studies kind of looking at the effect of these anti-inflammatory properties in patients that are kind of separate from their anticoagulant properties. And so low molecular weight heparin actually can decrease levels of interleukin-6 through inhibition of NF-kappa B pathway and ultimately kind of reduce this cytokine storm. So that has been one of the kind of interest in terms of looking at anticoagulation in this patient population. So does heparin actually decrease inflammation in patients with COVID-19? So this was a study attempting to look at that, and what you see here are images of interleukin-6 levels, lymphocyte percentage, and D-dimer. And so these C1, 2, and 3 groups are the control groups who did not receive low molecular weight heparin, compared to the H1, 2, and 3 groups, which did receive low molecular weight heparin. And looking at the interleukin-6 on your left, you can see that 1 is the start period of the trial, 2 is the end period of heparin treatment, and end period of trial. So for patients who did not receive heparin, there was no significant change in interleukin-6 levels between the start and end of the study period, while there was a significant decrease in interleukin-6 levels in patients who received low molecular weight heparin from the start to the end. And the difference between these two groups was statistically significant. Similarly, with lymphocyte percentage, patients who received low molecular weight heparin had a significant increase in lymphocytes compared to those in the control group who had no significant difference in levels. And last, looking at D-dimer levels, there was no significant change in D-dimer between patients in the control population, while there was a significant reduction in D-dimer levels in patients who received low molecular weight heparin. So possible, especially in terms of the inflammatory effects. So this comes from the current COVID-19 BJC guidelines, which Morey and I both helped with a large group of providers to develop to guide management. And the studies that I've just showed you, in addition to patient factors, so renal insufficiency, need for interventional procedures, being critically ill, have all really propelled our guidance statement as well as nationwide guidance to kind of preference unfractionated heparin or enoxaparin, low molecular weight heparin, as the initial treatment for venous thromboembolism in patients with COVID-19 or those with a high suspicion. In terms of treatment discharge, that's again really based on patient factors. We have no indication that this patient population is at higher risk to fail any particular type of anticoagulation, so direct oral anticoagulants, Lovenox, et cetera. There has been a push to limit initiation of warfarin in general in patients with thrombosis with and without COVID-19, given the increased need for monitoring in those patients and trying to limit patient and provider contact when unnecessary. So then I'll close quickly in the next 2 or so minutes, and we'll have a couple minutes for questions on the question of extended thromboprophylaxis in patients with COVID-19. So do patients admitted for COVID-19 require extended thromboprophylaxis at discharge? And again, as before with everything else, we have no clinical trials in COVID-19 to guide this. What we do have are very large clinical trials from acute hospitalization for medically ill patients looking at this. And what these studies looked at was what was considered standard extended prophylaxis, which was 10 to 14 days of low molecular weight heparin, and compared it to extended thromboprophylaxis, which is about 30 to 40 days or so of a direct oral anticoagulant, so betrixaban, rivaroxaban, or apixaban. And you can see that each trial had slightly different inclusion or exclusion criteria, but one criteria was an acute hospitalization for a specified list of diseases. One of those was acute infection. So the COVID-19 patients would all meet that, and then they would have to meet additional risk factors to be eligible for the studies. There was a meta-analysis that looked at outcomes of these 3 studies in combination with 2 other large studies looking at extended prophylaxis. And extended prophylaxis, so basically doubling the duration of prophylaxis post-discharge, significantly reduced the rate of symptomatic venous thromboembolism after discharge from the hospital by almost 50%. However, it also increased the risk of major bleeding about 2-fold. Now, I mean, the risk of major bleeding was less than a fraction of percentage, but nonetheless, it still doubled that risk of major bleeding. And so what we're recommending, and what several of the guidance statements, Anticoagulation Forum, American College of Cardiology have recommended, is that this be considered on a patient-by-patient basis, should not be a blanket practice. If you are discharging a patient who you anticipate to have significant immobility upon returning home because they're still recovering from their disease or other factors, then you could consider extended or standard duration prophylaxis at discharge. And so that is all that we have, and I think we would both be happy to entertain any questions.
Thank you both for a wonderful talk today. These are QR codes for ABM. Give me a second and I will pull up the CME codes. Okay. And with that, we'll start taking questions. Okay. First question I have, and feel free to jump in. The question is, what about COVID positive patients who are managed at home?
So that's a good question and an area of interest, but unfortunately, we just don't have data from that patient population. And I think that if data does come out, that it has to be interpreted very carefully. So if you're talking about a COVID-19 patient managed at home in the state of Missouri where our systems are not overwhelmed, that patient is likely to be very different from a patient managed at home in New York or somewhere like Italy where their hospital systems were overwhelmed, and you're likely to have much sicker patients at home. And the image that Morey showed in the very beginning, showing kind of where the bulk of the disease is likely where our studies are going to come from. And so again, when you see those studies come out that are addressing this question, which I anticipate they will, they need to be interpreted with a kind of grain of salt in terms of what to do. I wish I could provide further guidance, but just in the absence of data, it would be such a individual decision based on the characteristics of that patient.
Okay. Next question. Do you feel that there is a D-dimer cutoff for which we should use therapeutic anticoagulation in patients?
So initially, when the D-dimer literature was developing, people did think that just having a high D-dimer was an important marker and a risk for clotting. So there was some early enthusiasm to anticoagulate people just based on the D-dimer, and the cutoff that was often used was either 6 or 8-fold the upper limit of normal for whatever of those D-dimer assays you've used. Now, that literature has matured, and Kristen and I and other people have talked about this, and I think the wind is blowing more towards the idea that just the D-dimer alone would not be a strong marker to certainly therapeutically anticoagulate somebody. You might consider an intermediate dose for a very high D-dimer, intermediate dose of anticoagulant, but that's not clear, like most of the literature.
Yeah, I agree with Morey on that. The population where I'd have higher levels of concern is really the intensive care unit population, which just based on the numbers that we're seeing and nationwide guidance are really strongly starting to favor at least an intermediate dose prophylaxis, just given the high incidence in this patient population, which is mostly where you're going to see these D-dimers that are above 6 times the upper limit of normal.
Okay, give me 1 second. I'm going to put back up the maintenance of certification. Okay, a few more questions. So question is, what are the genetic factors that are associated with decreased DVT/P risk in Asians? I'm sorry, in Asians.
I don't know of any genetic protective factors. I think part of that may come from the idea that things like factor V Leiden and prothrombin gene mutation are more prevalent in people of European heritage. I don't know of any factors that are protective off the top of my head.
Okay. Similar question, or not similar, but another question. The inpatient guideline, there was a recommendation for transfusing platelets of less than 25,000. The question is, how does one decide when to transfuse since the 25,000 is higher than usual?
I'm assuming that this is referring to patients with a diagnosis of venous thromboembolism or a very high clinical concern. So you're giving therapeutic anticoagulation to that patient. So there's actually limited data in this setting, and that 25,000 is not a strict cutoff. You have to take into account patient clinical factors, but where those numbers come from was actually high-risk patient population for VT. It comes from the cancer patient population who are also at high risk of bleeding. And just looking at those patients that when providers discontinued anticoagulation for platelet counts of less than 50,000, these patients still had risk of thrombosis or propagation of their thrombosis. And so an observational study looked at transfusing these patients or having the dose of low molecular weight heparin for treatment of their venous thromboembolism. You'll see other people reference kind of 20,000 to look at numbers or staying at 50,000. And again, there's not large randomized trials looking at these outcomes. These are from smaller observational studies.
And then just to emphasize that those severe thrombocytopenias are not typical in COVID patients. So we had put that in as just try to be complete when those guidelines were developed. But in fact, that's not a very common finding and probably should be investigated for some other cause rather than just the COVID infection itself.
Okay, and in the interest of time, this will be the last question, but we'll do a combination of 2 questions because I think they're on the same similar wavelength. So first part is, does the hypercoagulopathy in COVID-19 reflect significant endothelial cell damage by the virus, i.e. what initiates the coagulopathy? And then going along with that is it thought that microembolism causes other reported tissue damage, i.e. like heart, liver, kidney, etc.?
So I think I think the answer is yes to both. I think there is significant endothelial damage, vascular damage, an inflammatory mechanism that I think Kristen had a slide of mentioning that. And in the autopsies that have been done, and some patients have had biopsies, you do see microthrombi. They're generally fibrin rich rather than platelet rich, but they can certainly glom up your kidneys and other organs, probably kidney and lung most typically, but other organs can be involved as well.
All right. Well, thank you so much for taking time to be with us today. There were questions about this being posted. So yes, this lecture will be posted on both the Wustel box for internal medicine, as well as our link to the rest of the COVID-19 lectures that we've been doing. So these slides and lecture will be available if you would like to review later. And then join us next week as we will continue our talks on COVID-19, same time, same place. Thank you.
Thank you.